and recognized globally as the top researchers in their respective fields of inquiry, both within and outside academia. So let me begin by introducing the four panelists through their biographies before turning it over to our first speaker. And after the four speakers have had their chance to speak, then we will entertain questions from the audience. So we'll have a question and answer period after the last speaker. Okay, so I will start with the biography. The first speaker is Dr. Mosoka P. Fallah, and Dr. Mosoka Fallah runs an NGO providing healthcare for poor communities in Liberia. And Mosoka is the founder and executive director of an NGO in Liberia called Refuge Place International to address the issues of access to quality, affordable healthcare that impacts maternal and infant mortality among poor urban and rural dwellers in Liberia. He and his team are currently working to rapidly scale up this successful model across the country. Community involvement and empowerment is central to the way they work. He was awarded the USAID Liberia Health Worker and Development Person of the Year 2017 award for his work with Refuge Place. He was the recent past Director General of the National Public Health Institute of Liberia, NPHIL, that he co-founded and was enacted by an act of legislature and approved by then President, Her Excellency, Madam Ellen Johnson Sirleaf in 2017. NPHIL was developed as a consequence of the 2014-2015 Ebola outbreak, which resulted in 11,400 infections and 4,600 deaths in Liberia alone. It has been on the forefront of the COVID-19 response. He has developed extensive skills and knowledge across a vast expanse of public health response when he first served as the Deputy Director General for Technical Services. Dr. Fallah completed his PhD in immunology at the University of Kentucky. He subsequently studied global health with a concentration in infectious disease epidemiology at the Harvard Chan School of Public Health. When Ebola outbreak occurred, he leveraged his skills in epidemiology and program management to lead the Ebola response, launching an active case finding system that became a recognized model for epidemic control. For his work building community level trust in the Ebola response, Dr. Fallah was named the Time Magazine's Persons of the Year in 2014. In addition, Dr. Fallah is currently the principal investigator in Liberia of several NIH-sponsored studies on Ebola, including a natural history study of the largest cohort of Ebola survivors in the world. These studies are part of the Prevail initiative, which he worked extensively with the Ministry of Health of Liberia, medical centers, and nonprofit organizations to jumpstart. In addition, Dr. Fallah serves as a part-time faculty member at the Harvard Medical School Department of Social Medicine. In June of 2015, he visited the Democratic Republic of Congo as part of a team of local NGO and York University in Canada to evaluate and advise on the Ebola response. He has led the establishment of the first Master of Public Health program in the College of Health Sciences at the University of Liberia, where he once served as the chairman of the Department of Biochemistry in the A.M. Dogliotti College of Medicine. In total, Dr. Fallah's extensive experience includes more than 10 years experience in development work with consultancies in the United States Agency for International Development, USAID, Cheminonics, the President's Malaria Initiative, the World Health Organization, the United Nations Development Program, Doctors Without Border, and Action Against Hunger. He has won several prestigious national and international awards. The second speaker, Dr. Svenn-Erik Mamelud, is a research professor and head of the Oslo Met Center for Pandemic Research. For 26 years, he has studied the demography of epidemic diseases with a focus on the 1918-1920 influenza pandemic. Mmelud has published more than 70 papers on these topics and has been a visiting scholar at the University of Wisconsin-Madison in 2001, at the Umeå University 2006-2009, and Penn State University in 2008. He has since April 2017 been the president of the Norwegian Demographic Society, and in the academic year 2022-23, he will lead a research group investigating why indigenous people are so vulnerable towards pandemics at the Center for Advanced Studies at the Norwegian Academy of Science and Letters, Oslo, Norway. Dr. Roger Keil, our third speaker, is a professor at the Faculty of Environmental and Urban Change, York University in Toronto. He is the author of Suburban Planet, Polity 2018, co-editor with Judy Brafman of Public Los Angeles, a Private Cities Activist Futures, UGA Press 2020, with Shufei Ren of the Globalizing Cities Reader, Routledge 2017, and with Kay Murat Duni and Murat Koglu of Massive Suburbanization, U of T Press 2019. Keil's research areas are global suburbanization, cities and infectious disease, regional governance, and urban political ecology. He is a co-investigator in a partnership grant on regional student mobility and currently works at the intersection of global urbanization and emerging infectious diseases, including research under the leadership of Dr. Harris Ali and Dr. Mosoka Fallah on community responses to Ebola virus disease in urban West Africa and the DRC. Past work with Ali resulted in the book Network Disease, Wally 28, which is the Globe and Mail listed as one of the top 10 books that offer lessons from past pandemics. At the outset of the COVID-19 lockdown, Keil is also conducting comparative research with colleagues in Berlin, Milan, and Toronto on the relationship of the COVID-19 pandemic and cities. And our last speaker is Dr. James Orbinski, who is a professor and the inaugural director of York University's Dodele Institute of Global Health Research. As a medical doctor, a humanitarian, practitioner, and advocate, a best-selling author, and a leading scholar in global health, Dr. Orbinski believes in actively engaging and shaping our world so that it is more just, fair, and humane. A champion of health and humanitarianism, throughout his career, Dr. Orbinski has extensive leadership, advocacy, and research experience in global health. He has worked providing medical humanitarian relief in situations of war, famine, epidemic, disease, and genocide with Médecins Sans Frontières, Doctors Without Borders, MSF. He was elected international president of MSF from 1998 to 2001, accepting the Nobel Peace Prize awarded to MSF in 1999. He is the author of the award-winning and best-selling book, An Imperfect Offering, Humanitarianism in the 21st Century. Dr. Orbinski holds a BSc from Trent University, an MD degree from McMaster University, and an MA in International Relations from the University of Toronto. He is an officer of the Order of Canada and has received the Meritorious Service Cross for his leadership in providing direct medical relief in Kigali during the 1994 genocide in Rwanda. He is a member of the College of Family Physicians of Canada, an avid canoeist. Dr. Orbinski lives in Guelph with his wife and their 3 children. So thank you all, and thank you for agreeing to participate today. And we're all looking very forward to your presentations. So I'm just seeing if, yeah, Jude, did you want to say something?
Yeah, I'm sorry because I sent the message to you because we just have Dr. Chapenda with us.
Okay.
And Dr. Chapenda is the chief of bureau at the direction of surveillance, epidemiological surveillance at the Ministry of Health of the Democratic Republic of the Congo. And Dr. Chapenda va pouvoir nous parler assez rapidement de la situation épidémique qui se vaut maintenant dans l'Est de la République démocratique du Congo. He will give us an overview. And I know we have, most people are Anglophone, so English speaker, but what we can do is maybe Elise or Saba can help us to translate after. So Dr. Chapenda, est-ce que vous pouvez ouvrir votre micro et nous parler de la situation actuelle et nous expliquer aussi qu'est-ce qui est mis en place justement pour freiner la situation épidémique actuelle?
Merci beaucoup, Monsieur Jude. Je voudrais partager mon écran, s'il vous plaît, pour pouvoir entamer ma présentation. Vous pouvez me permettre
Vous pouvez.
de partager. OK. D'accord. Oui, j'espère que tout le monde...
Oui, on voit votre écran.
Tout le monde à l'écran.
Oui, très bien.
D'accord. Rapidement, donc, comme vous m'avez présenté, je travaille à la direction de surveillance épidémiologique en République démocratique du Congo. Donc, il m'a été demandé de pouvoir brosser la situation épidémiologique et l'état de la réponse, n'est-ce pas, par rapport à la maladie à virus Ebola dans notre pays. D'abord, le contexte, c'est que tout remonte au 6 février 2021, avec la confirmation par le laboratoire INRB de Butembo de la présence d'un virus Ebola dans un échantillon qui a été prélevé chez une patiente dans la zone santé de Biena, l'aire de santé de Masoya. Je vais vous montrer la carte après. En fait, cette femme-là, c'est l'épouse d'un guéri de la maladie à virus Ebola lors de la dernière épidémie de 2018-2020 dans la même aire de santé. Vous pouvez traduire?
Sabah, you are able to do it?
I'm not in.
No, I say, okay. Yeah. I will go slowly, okay, to allow the translation.
So maybe Elise or Sabah, can you help? Sabah, Elise is muted. Can you
Unmute her.
unmute her? Thank you.
All right, she should be good to go.
Hi, everyone. Thank you very much for being here with us. So just for the initial background, the current outbreak dates back to February 6th with confirmation of case 1. And this was the wife of one of the Ebola survivors from the 2018-2020 epidemic, and from the same healthcare center, Masoya, in the health region of Biena.
Et donc, lorsque cette femme, plusieurs jours avant, elle a commencé à se sentir mal, elle a consulté dans un poste de santé, le poste de santé de Ngoubi, où elle a été observée pendant 4 jours. Ensuite, son état s'est détérioré. Elle a été référée à un centre de santé, le centre de santé de Masoya, où elle a été hospitalisée pendant 3 jours et elle a présenté des signes hémorragiques. C'est ce qui a fait suspecter la maladie à virus Ebola. Le centre de santé a pu prendre un échantillon de sang. Ensuite, la malade a été transférée à l'hôpital de Matanda. C'est dans la ville de Butembo, la zone de santé de Katwa, où elle est décédée le 4 février 2021.
Okay. Initially, when she presented to a healthcare center feeling unwell, this individual, she was under observation for 4 days before being hospitalized in Masoya, where through hemorrhagic symptoms, it became suspected she had Ebola. She was tested and tested positive and transferred the same day to the Matanda Hospital in Butembo, where she died on the 4th of February.
Pardon. Il faut préciser que entre le prélèvement au centre de santé Masoya et la confirmation, il y a plusieurs jours qui se sont passés, 2-3 jours qui se sont passés. L'échantillon est arrivé en retard, en retard au laboratoire. Lorsqu'elle est décédée le 4 à l'hôpital à Katwa, elle n'a pas été traitée comme un cas suspect de MVE, c'est-à-dire même l'enterrement n'était pas sécurisé. C'est après qu'on a su que c'est une positive. Ça, c'est une précision que j'apporte.
Oui, ça c'est important. Okay, pardon. So she was tested in the second place she was transferred to, but they didn't get the results for a number of days, I suppose until the 6th of February, since that's when it was confirmed. And there were some delays in getting the results so that she was not treated as an Ebola patient and even her burial was not treated according to the protocols recommended for an Ebola patient.
Alors, ainsi, lorsque le résultat est sorti le 7 février, le ministre national de la Santé a annoncé l'épidémie et il y a eu déploiement sur terrain d'une équipe provinciale ainsi que la division provinciale de la santé du Nord Kivu. Tout de suite, cette équipe a mis en place un certain nombre d'activités pour pouvoir contenir l'épidémie.
So with the announcement on the 7th of February that an Ebola outbreak, or that Ebola was back, the Ministry of Public Health did send a team to begin to coordinate the response in Butembo. Yeah.
OK. Il faut dire aussi que les partenaires sont aussi présents, n'est-ce pas, à Butembo pour prêter main forte au ministère de la Santé.
And it should be noted that partners are also on the ground lending important support to the Ministry of Health.
Voilà, ça c'est juste pour donner une idée de la zone de santé de Biena et les zones de santé tout autour. Vous avez la ville de Butembo avec les 2 zones de santé, Butembo et Katwa. Et à côté, vous avez Biena, le début de l'épidémie. Et vous voyez que c'est entouré de plusieurs zones de santé susceptibles également d'être... enfin, ce sont des zones à risque.
Okay. So just showing us on the map where the focus of the current outbreak is, and pointing out that that's Biena, but also Butembo and Kalanguta and all these surrounding areas are also at risk.
Alors, donc pour le moment, il faut dire que le dernier cas confirmé remonte au 13 février 2021. Nous avons 4 décès. Ce sont les 2 premiers. Ce sont les 2 premiers cas qui sont décédés. Donc, voilà le tableau qui présente la situation globale.
Okay, so here's a representation.
You can translate, please.
Yes, thank you. I missed a little bit in the middle there, but la connexion n'était pas bonne pour 1 minute, mais je pense que j'ai compris. So this is the situation at the moment. You can see that there's been 4 confirmed cases as of the 16th and 2 deaths in community.
Voilà, ça, c'est la chaîne de transmission. Comme vous voyez, le premier cas, attendez, je suis en train... Est-ce que vous voyez mon pointeur de l'ordinateur? Je ne sais pas si vous le voyez.
Oui. C'est bon.
OK, d'accord. Très bien. Donc, le cas est ici, qu'on considère comme le cas index, une femme de 42 ans de sexe féminin, cultivatrice, elle est au 25 janvier. 25 janvier 2021. Elle a présenté, elle est décédée le 4 à l'AGR de Matanda, la zone de santé de Katwa. Elle a été enterrée dans la zone de santé de Moussienene. Mais alors, cette femme, on a essayé de faire, une fois le séquençage de l'ARN viral, on a trouvé d'Ituri de 2018 avec un faible taux de substitution ou de mutation. On a trouvé par exemple qu'il n'y avait que 5 mutations entre le virus de l'Ituri de 2018 et le virus qu'elle avait. C'est ainsi qu'on a considéré que c'était une source persistante, parce que si c'était une source par transmission continue, on a essayé d'évaluer le nombre de mutations. En principe, on devait avoir au moins 35 mutations. Si on considère la fin de l'épidémie jusqu'à partir du moment où elle a été, cette femme a été contaminée. Mais vu le faible taux de mutation, on a considéré que c'était une source persistante. Alors, on a posé des hypothèses parce que son mari, c'est un ancien guéri. On s'est dit peut-être ça vient de son mari, ou bien ça vient d'elle-même, mais c'était inaperçu à l'époque, ou bien ça vient encore d'un autre cas guéri. Vous pouvez traduire cette partie.
Alors, oh yes, so the first case, who is the wife of the Ebola survivor, when they ran the DNA tests on her ADN, Diana, they did a testing on her sample, and they found that there were only 5 mutations compared to the 2018 strand of Ebola, which suggests that this is endemic, a persistent source, either from her husband, who's a survivor, or maybe she's been carrying it and it hasn't manifested, or maybe there's someone else. But some of the hypotheses certainly suggest that this is not a novel or strand. It shows that the 2018 Ebola is still present. Yeah, that's the
Donc, les investigations plus approfondies continuer. On peut près, comme vous le voyez, 3 autres cas, dont un décès et 2 autres cas. Et parmi les 3 autres cas, il y a une femme de 60 ans qui est ménagère. Semble-t-il, elle avait des contacts avec cette femme au niveau du poste de santé où elle avait été hospitalisée. Et puis le deuxième cas à qui elle a transmis la maladie, c'est une femme de 22 ans, elle est ménagère. Cette transmission a eu lieu probablement à l'hôpital, là où elle a été, la première femme a été hospitalisée dans la zone de santé de Catois. Et enfin, le troisième cas ici, à qui elle a transmis la maladie, c'est une infirmière qui travaille justement dans cet hôpital général de référence à Catois.
Okay. So the 3 additional cases are all contacts from the healthcare trajectory of this woman. So the 60-year-old woman has passed away, and then there's a second contact, as you can see in the middle, and a third contact who is a nurse from the hospital she was referred to.
Voilà. Donc, alors, quelles sont les actions qui ont été mises en place? Sur le plan d'abord coordination, au niveau national, il y a une feuille de route rapidement qui a été écrite pour pouvoir mobiliser l'argent, une feuille de route pour 1 mois. Mais sur le plan opérationnel, au niveau de la province, on a élaboré un premier draft d'un plan d'action opérationnel. Une équipe du niveau central est descendue dans la province. Je fais partie de cette mission du niveau central. Pour le moment, je me trouve dans la province du Nord Kivu, précisément au niveau de la ville de Butembo. Il y a des réunions de coordination qui sont dirigées par le ministre provincial de la Santé lui-même. Il y a eu même lancement officiel de la vaccination hier. Il y a eu le lancement officiel de la vaccination. Les points de presse également sont tenus par le ministre provincial. Ça, c'est du point de vue coordination.
Okay. On the coordination side.
You can go
yes, on. Thank you. So on the coordination side, there's nationally, there's a plan for the next month that was developed rapidly. There's also an action plan for the province, which for the response within the province. And there are coordination meetings held out of the provincial ministry, and that is where the doctor is speaking from at the moment, Butembo, and they're coordinating from North Kivu with their partners. There's also been, as of yesterday, the launch of vaccination for the eligible contacts, and there's also press meetings being held by the Provincial Ministry of Health of North Kivu. I suppose c'est tous les jours les points de presse.
Voilà, les points de presse. Voilà. Sur le plan surveillance, France, il y a une organisation par rapport aux différents volets de la surveillance, notamment le contact tracing, hein, le suivi de contact, la vaccination, l'organisation de la gestion des alertes, mais également le suivi ou plutôt la recherche active dans les formations sanitaires et également la tenue et le toilettage des bases des données par rapport notamment au contact.
Okay. So these are just some of the surveillance, key surveillance activities. So they're doing the contact tracing, they're also seeking the contacts for vaccination, and they're organizing the alert or notification system is in place, as well as the sanitation of areas exposed through the contacts, from my understanding.
No, this is just to organize the database, toilettage, to organize the database, yes.
Okay.
Okay.
Yeah, it's just, well, there you said it. Go ahead.
Yes.
Poursuivez, je passe.
Alors, pour la prise en charge des cas, il y a 2 malades qui sont en hospitalisation, qui sont pris en charge au CTE de Catois. Donc, il y a 2 malades qui sont déjà l'appliquent spécialement. Allez-y pour la slide.
Okay. On vous a perdu un peu, mais vous avez fait juste le premier point, je pense. That there are 2 people ill currently in the Ebola treatment center in Katwa.
Okay. Please, can you allow me to plug, because I'm...
Yes.
Donc, je dois me connecter parce que je suis lobat, hein, je m'excuse.
No problem. He's just going to plug in his computer.
We've all been there.
Yeah.
As we're waiting, I would like to actually thank Dr. Tshipenda for this very important update, situation report. So many of us thought that this virus would be conquered by the introduction of the vaccine, but it's a persistent, as my colleague Dr. Mosoka Fallah has once mentioned in a conference. I mean, the persistence may be because the virus stays in the semen of the people and therefore becomes endemic to the region. And this seems to be the case in Eastern DRC. But I'm happy to see that the response in the Eastern DRC has been very quick and that they're keeping track. So that bodes well to the success of the next campaign, and hopefully it will not reach the geometric stage.
Oui, et juste, je voulais juste aussi dire à Dr. Tshipenda et Dr. Harris, comme nous sommes pressés par le temps, est-ce que Dr. Tshipenda pourrait prendre juste 1 minute pour résumer le tout et puis après on pourra continuer parce qu'on est très pressé par le temps.
Voilà.
Yeah.
Tout à fait. Je m'excuse vraiment. Ma machine était low-bat à cause, j'ai dû travailler dans l'avion. Donc, voilà, il y a des actions qui sont déjà menées sur les différents volets, mais il faut dire qu'il faut passer à échelle. Il faut poursuivre le listage de contacts parce que nous pensons que nous ne sommes pas arrivés encore à cerner tous les contacts. Il faut organiser la prise en charge, il faut réhabiliter le centre de traitement qui est le centre de 2018, mais il faut le réhabiliter et passer l'ensemble des actions à échelle. Donc voilà, pour le laboratoire, j'aimerais dire que les laboratoires fonctionnaient de tout ce temps avec l'appui de l'INRB au niveau de Butembo et au niveau de Goma. Mais il faudrait, avec le nombre de cas suspects, les alertes, il faudrait renforcer ce laboratoire en intrant, en réactif et peut-être en appareil aussi GeneXpect. Voilà plus ou moins, en résumé, ce que nous pouvons dire des actions actuelles par rapport à l'épidémie de MVE dans la province du Nord Kivu. Merci.
Oh, merci beaucoup, Dr. Chapenda. I will quickly summarize that the plan is underway, but there is a need to scale up. There is a need to, they do believe they have some more contacts to trace down. There's also, they're in the process of refurbishing the 2018 Ebola treatment centers. Luckily, the laboratories, the sections of the National Laboratory in Goma and Butembo are still active, and so they're in place, but there's a lot of work to be done. Thank you very much, Dr. Chapenda.
Yes.
Thank you, Elise, Dr. Nouvet, and I think we can go back to the agenda, and after that, if people have some questions, we can take them. Harris, we can
okay. Yeah, thank you, Jude, and thank you, Dr. Chapenda. That was a very important update you have given us. As Jude says, let us return to the program. And our first speaker is Dr. Mosoka Fallah. Mosoka, I've already introduced you. Are you there?
Yes.
Yes? Okay. You're intermittent. Let's try.
Okay. Hi. Can you get me now?
Yeah, I can hear you.
Hello. Sorry, I'm having some shortages on my internet connectivity, but thank you very much for the introduction.
Okay.
I sent a presentation that I wanted to use. I wonder is available so that I can present that.
Yes, it's.
Are you getting me? Are you hearing me?
Yep, I have your presentation.
Are you getting me, sir? Some string reaching. I'm having hello?
Yes, Mosoka.
Can you hear me well now? Is it better?
A little bit better. Yeah, we can see you.
All
too.
right, thank you very much. Yeah, okay,
okay.
I sent a PowerPoint presentation. Is it possible to show that?
Yeah, I'm gonna ask Sabah. Can you pull it up?
I have a PowerPoint that I sent.
We see it. Masoka, we see it. Liberia and COVID-19.
All right, thank you very much. All right, basically.
There we go.
Yeah. So basically, I was asked to present some of the experience and the figures we learned from Ebola that we're able to use in the immediate response to COVID-19. So next, the outline. I mean, little history about Liberia. And then our unique book comprising of the same people and involved in trade. And so there's always a risk in the Mana River Basin. We have our health system based on health districts. There are 15 counties and 93 health districts. And so we have priority diseases following the WHO guideline that we report every day. There is active background. Next slide. Prior to the Ebola, Liberia had gone through a 14-year devastating civil war. There were only 58 medical doctors. Most of the health infrastructure was destroyed. New and the educational system was disrupted, and so nurses and healthcare workers were inexperienced. We had a very weak surveillance system. At the time, most of our samples were either taken to Senegal, Sierra Leone, or to Europe for analysis. We could not even do basic diagnosis prior to Ebola. Next slide. Next, okay. Now, so Ebola and our health system in the post-Civil War Liberia was a perfect storm that will lead to massive disruption, economic disruption, and livelihood, as I will show later. In the midst of this perfect storm of a destroyed, weakened health system, with no lab and few doctors, and an infectious disease like Ebola started in 2014, March of 2014. It was after several days before we could be able to tell if we had Ebola, because the specimen had to be taken to the river, cross in a canoe to Conakry, and then to France before the diagnosis could be confirmed. As a result, we had 8,000 persons affected. We had over 4,300 deaths. Of the 11,000 deaths from Guinea, Sierra Leone, and Liberia, we contributed 4,000 of those deaths. So that can tell you over 50% of all the deaths came from Liberia alone. Not only that, because of our inability to develop an effective, resilient health system, Ebola caused a complete shutdown in our public and private sector. There were no trade, and we had uprising, people died, and there was massive resistance that predate Ebola due to massive corruption and increasing poverty. Next slide. Can we have the next slide, please? Basically, this is the economic. This tells you the economic impact of the outbreak on our country. The number of persons that got infected, the number of healthcare workers that got infected, and the number of healthcare workers that died across the 3 countries. Liberia accounted for the highest number of healthcare workers that got infected and died. Next slide. Okay, basically you can see not only were the health system affected by Ebola, the number of healthcare workers, but educational system became disrupted. The number of children had to be taken out of school to make room for Ebola. So basically the whole system, it further made our country to be a fragile state. Infectious disease having security implication. Next slide. So right after, as Ebola was coming to an end, we began to look at what can we do to make Liberia to be robust and more resilient. So we define a resilient health system as a health system that has the ability to detect and respond to an infectious disease while at the same time maintaining normal health services. That's not a resilient health system. It took Ebola to destroy the entire health system and has security and economic implications. So one of the key things we wanted to do was to develop a resilient health system, a system that will be able to detect and respond to outbreak, and at the same time, not allow the normal health service system to be disrupted. And by doing that, we allow the economic to flow smoothly. And so those became our talks process. And so we developed a strategic document called Resilient Health System, building 9 pillars. We developed those documents, and one of the things that was asked for in the 9 pillars was the establishment of a public health institute that would do early warning and surveillance system. Within the institute, there will be a robust laboratory system and ability to transport samples anywhere around the country within 48 hours to be able to test any suspected infectious disease. Also to build an effective public health system, to build different kind of public health technicians. So we introduced the field epidemiology training program along with CDC. So there are different tiers, the basic up to the intermediate and the degree holder. We sent some people to Ghana, some were trained in country with professor from University, Emory University. We train all cadre. And of all of our 880 health facilities, we're able to train surveillance focal person. And those persons' job was to ensure they record and report to us the priority disease within 24 hours. And so because of that, we developed a strong early warning and surveillance system so that we will not go back to what we saw happening during the Ebola. That's what the key lesson we'll learn. A resilient system with an effective early warning is critical for protecting the security, the economy, the health of a nation. That was a key lesson we took as a result of Ebola. Next slide. And so we developed the institute. As we get to the next slide, we developed the Public Health Institute. So prior to COVID-19, our system began alone were able to detect 17 different disease outbreaks, including re-emerging infectious diseases. Monkeypox have been eliminated from Liberia in the 70s, but we're able to diagnose it. Very soon we realized that we're now detecting more diseases. And like one of my professors said to me, when you look for the disease, you will find it. So most likely in time past, people were getting these diseases and they were dying. But now with a robust health system, with an ability to transport specimens across the country within 48 hours, and a robust laboratory system to be able to test within 48 hours, it gave us an edge. The second thing, we have developed a strong community network that could detect and respond to disease. I quite remember one year I was on my way to the Philippines for a WHO meeting. I was on the airport by 1 a.m. when I got a call from West Point that a group of people had gone to a wedding and many of them were having diarrhea and vomiting. In less than 30 minutes, the local community rose up, detected the cases, and we sent the ambulance. So we realized that from the level of the communities and as a health infrastructure, we have built a robust system that was early December when we began to hear about the outbreak of disease in China. We did an analysis and said, what can we aware? And so the first thing we did, we went to the airport and the major entry point and analyzed the data of people coming into the country. We realized that just between December and January, 1 second, we'll work on the sound. Between December and January, there were 330 persons from China, broken down into 3 categories: students, Chinese businessmen, and Liberian business people going to China. And so we realized from that point at the airport. And so we started to activate an enhanced screening at the airport, at our major airport. That was done as early as late in December, in January of 2019. While many countries were not anticipating, we have gone ahead of the curve and prepared the country to get ready. We introduced a screening measure. Next slide. And so long before they could declare public health emergency of international concern, based on our experience with Ebola, we have gone ahead, set up the coordinating meeting, set up the various pillars, started to train the counties into, can you assist us? And the Chinese gave us what they were doing in China, in Wuhan, and we used that to start to train as early as January of 2020. The issue mechanism, we developed 9 different pillars. The coordination pillars were meeting every day, 7 days a week. In February of 2020, let me just, sorry, 1 minute. So we introduced the coordination. We set up the treatment units at the military barracks. We activated the laboratory. We sent one of our men to Senegal at the Pasteur Institute to get trained how to diagnose COVID-19. So basically, we had this payload that already set. All we did, we activated February. In the same February, we're able to start introducing isolations. We took hotels and started to isolate people coming from China. Liberia was the first country to do that. As a matter of fact, Ghana and Sierra Leone had to borrow our model preparedness in anticipation of the outbreak. Next slide. I will try to run through these quickly given my time. So we set up a system. We went ahead and reactivated all of our payloads we have from Ebola. We interlinked all of the agency. We met the president and briefed the president and created a presidential task force called the Special Presidential Task Force on COVID-19, headed by the president. We developed a multi-ministerial intervention involving the military, the police, foreign affairs. We're all involved, one government approach. We also went within the county, set up a response system. We got involved with the Mano River Union and the ECOWAS to prepare the region. Next slide. And we started to work through the rumors. So basically, we had each of these set up, we were prepared. So by the end of February, Liberia was fully prepared in terms of laboratory training, in terms of detection, in terms of controlling potential sources of cases. We call a meeting with all the embassies and ambassadors. We met the embassies and we begin to coordinate with the embassies and all the major airlines so that by the time an airline arrived, they'll give us the passenger manifest and we'll review the manifest. And so we developed SOPs, we went through information, we worked with the community. So each of these pillars were working. You can just move ahead. So we set up a surveillance system. We started to track people coming from the country of high risk as they enter Liberia in the airport, we track them. Next slide. So we set up each of these pillars were working. Our most aggressive pillar after surveillance was the port of entry. We activated the airport and all of our land crossing and begin to track the disease across the West Africa. Next slide. And so people coming from China, eventually from Italy, were taken and sent to the hotel and monitored for 14 days. After 14 days, they were allowed to go home. We used a military hospital to prepare for the eventual confirmed case. We developed the military hospital, worked with the military doctors, set up the beds, set up the isolation system. We did that. All of those were done between February and March. Next slide. So basically, each of the pillars that we had developed under Ebola, we activated them and started to strengthen them and try to align them along with COVID-19. Train our people along with COVID-19. As I said to you, the laboratory team was sent to Senegal. They received the training, they got reagent. They were back in the country in February. We set up the whole biosafety system and we're ready for testing in February. Next slide. Can we move faster? So basically, each of these pillars were set up. And so we started to work. One government approach, we commanded all government vehicles, non-essential vehicles were all commanded and sent to us to prepare. That's how we did it. We commanded, those were all lessons from Ebola. One of the key lessons from Ebola, I want to speak on logistics. At the close of Ebola, we worked with the World Food Program and we created 5 logistic hubs across the country. This is something for our brother from DRC. What we did is that these hubs are set and they have materials. Our desire is to ensure that within 24 hours, we can move logistics to any part of the country. All across the country, we set up logistic hub and we monitor the logistic hub to move PPE and material across the country. And so we went ahead and took a stock of the logistic hub across the country. And so we're able to quickly distribute materials in preparedness for the response. Next slide. Okay, so basically, as you can see, and so March 16, so with that slide, I can go ahead and conclude. We prepare ourselves, we had a public prepared. One of the things we did was we wanted a unified media response. And so we started working with the media. We created a media WhatsApp group. One of the things we rarely used was the media, the WhatsApp. We had a media WhatsApp group. We had a different WhatsApp group created. And so we're constantly coordinating with the media so that we could have rumor management because we did not want the public to panic. And we started to engage the communities. It was very important to get the community to be engaged ahead of time to get involved. And so once we had those systems in place, the team was working. There was one government. We had a government support. We did not have government, any support from any institution. The first $500,000 was raised by the government of Liberia to prepare for the response, to pay for the hotels. We tried our best. We thought we could prevent COVID, but on March 16, I got a call from one of our ministers, our directors, who had come from a meeting in Sweden, and I followed the procedure at the airport, went home, and he was sick, and he called me and said, Doc, I came from Sweden, and it looks like I have COVID-19. So I told him, stay at your house. I'm going to send a team to collect the specimen. The specimen was sent to the lab. It's a serious but funny thing. For that, I hadn't slept a long time. I usually woke up 5 a.m. But that day I slept to 8 a.m. I had worked for long. And when I opened my phone, I had over 27 missed calls. And the minister was laughing at me and said, Mosoka, you are waiting for the bridegroom. The bridegroom had arrived and you are not prepared. I said, but basically we had prepared and we had an outbreak. So we managed that case. And almost 50% of our first group of cases were in the isolation unit when we tested them and they became positive. And so we are happy to say, if you look at the recent publication by Wahoo, Liberia has the lowest number of cases, confirmed cases, in all 16 countries in West Africa. We have the highest number of mortality. However, we have one of the lowest mortality in our treatment unit because our physician had gained skills, our system had worked. We have learned one lesson that preparedness was important, that rumor is very important. Once you pick up rumor, you go into a survival mood. We had a public health system that was off for early warning. We had a laboratory system set up. We went back to our Ebola infrastructure and we rebuilt those infrastructure and not rebuild, but strengthen them, align them with the COVID-19, and we're prepared. And so and a friend of mine said to me the last time from Wahoo, when I saw the result, I said, wow, these results surprised me. Liberia is still the lowest. And he said to me, Mosoka, you don't like to take the honor, but this is because of what you guys did for Liberia. That's why Liberia can have the lowest cases. I know you are a very humble guy, but preparedness. And so we had a bad lesson from Ebola, but we have learned that lesson. You prepare, you build a system in place, a system that is agile, that you can activate quickly to respond is always critical. So those are our lessons. I always say it was the silver lining in the dark cloud. Ebola was one of our darkest clouds, but we have one silver lining. We're going to learn our lesson, and we're going to learn them well, and never be caught again like the way we were caught before with Ebola. Thank you very much.
Yes, thank you, Mosoka, for an excellent presentation. And it is good to see that something was learned from Ebola and it could be applied to the COVID situation, as you and I have talked about many times. The disease outbreak is not just a medical phenomena about logistics, but it involves a holistic response about community and rumors, and that aspect has to be incorporated in the response, and that's exactly what's done. So thank you, Mosoka. Let us move on to the second speaker, who is Professor Svenn-Erik Mmelud. And so if we can share the screen.
Thank you very much.
Yes, thank you so much for this nice introduction and for the two nice previous talks. I gave this talk for some Norwegian economists and epidemiologists last year who were using the so-called SER model to study epidemic curves during COVID-19. I'm here sort of relying on or using this so-called SER model to structure my talk, and I also use this the opportunity to ask questions about the assumptions of the SER model. In my talk, I compare COVID-19 with the 1918 influenza pandemic, and I mainly use global as well as Norwegian data and examples on the susceptible, on the infected, and on the recovered. That is either those that died or those that survives these two pandemics. So this first table is showing you first some pandemic outcomes. You have the Norwegian figures in red and the global ones in black, and you see, seasonal influenza is infecting something in the neighborhood of 5 to 10% each year. You have something in the neighborhood of 300,000 deaths and up to 650,000 deaths. In Norway, we have something like 900 excess deaths per year. We also assume that 0.1 of those that are infected die. When you move along to the 1918 flu pandemic, you see that a lot more are infected. That's sort of the chief feature of pandemics, that more people are getting sick. Sometimes lethality is also increasing, which it did in 1918. We're talking about something in the neighborhood of 50 to 100 million people who died, 15,000 Norwegians, and something in the neighborhood of 1 to 2% of those that were infected died from the 1918 influenza, and globally up to 5% died. In Norway, 0.67% of the population died, and that figure was more or less equal into the one for the US and for Canada. So for most high-income countries and Western countries, this figure, the mortality per population was way below 1%. And in the right-hand column, you see the COVID figures. We obviously don't know exactly how many people have been infected, but a number of studies are showing that something in between 2 and 20% or even more in some locations have been infected, according to antibody studies. Antibody studies in Norway shows that something that approximately 2% have been infected in Norway. We're talking about 2.5 million deaths globally. These figures are, of course, going to change, and only, if I could say, only 593 deaths in Norway. Global figures range between 0.1 and 2% when it comes to the infectious fatality rate. The last study from Norway shows that 0.12% have died given infection. And finally, you see the mortality figures at the bottom here. It's 0.03 at the global level, and in Norway 0.01. The figure for Canada, I think, is 0.06, so twice the figure of the global estimate, and the one for the US is 0.15%, so 5 times the global average. So who's really susceptible during pandemics? In theory, it's everyone, because you have a new virus, which allegedly no one is immune against. But this is not really true, not even in pandemic or SCR theory, because some had pre-existing immunity in 1918 towards the H1N1 virus, and it varied by region, ethnicity, and age, as we will see. And I claim in a paper published in 2011 that if it wasn't because a lot of the people had pre-existing immunity, it would have been even worse than the figures that you saw on the prior slide. So without this pre-existing immunity, it would have taken even more deaths than it actually did. And there's several studies out there now also on COVID suggesting that there might be some pre-existing immunity in the population, I don't know, especially among kids and adolescents, due to the fact that we have been through other types of coronaviruses. So that's one possibility, but here we need more research for sure to conclude on this topic. So who gets infected? Here I'm going to focus only on age, sex, and wave. And here you see a graph of influenza-like illness in Bergen in Norway. And at the top, you see the so-called summer wave of the 1980 flu pandemic. And the solid line is males, the dotted line is females. And you see that young adults had the highest ILE. And while You also see that men had a little higher morbidity than females in the summer wave, but you have a twist going on to the fall wave where you see that men report somewhat lower morbidity compared to women, which we believe is due to the fact that that going through the first wave conferred some type of protection to fight the next wave. This graph is just showing the number of lab confirmed cases by age and gender as of 15th of February 2021 in Norway. It's basically just showing that it's actually you have lab confirmed cases for all ages pretty much, but most of the cases you see among people in their 20s and 30s and 40s and 50s. And initially, going back to March 2020, I mean, the first ones to get infected in Norway were those, that could afford to go skiing and stuff, in Italy or in Austria. It was men living on the west side of Oslo, the wealthiest part of Oslo, bringing this disease back to Oslo. But later on, we have seen that also young adults and people in the 20s and even teenagers and kids can be infected indeed. This figure is now entering that landscape called recovery. And here we look at the risk factors for mortality, and basically the risk factors for seasonal flu, the 1918 influenza, and COVID are almost the same. So you see some of the same medical risk groups and socially vulnerable people who are at risk of a severe disease. But the one big difference is that during COVID and seasonal flu, it's the elderly that are most at risk. But during the 1980 flu, it was the young adults, those between 20 and 40 years of age. And as I have read the literature so far, pregnancy is not the risk factor so far for COVID, but this for seasonal flu and the Spanish influenza pandemic. This figure is showing mortality in Norway. This is PI mortality, pneumonia and influenza mortality in Norway. And the solid line is 1918, the first year of the Spanish flu pandemic. At the bottom, you see the seasonal baseline, pictured by the year 1917. And you see that the rise in mortality is driven mainly by young adults. And you see this clearer in this next slide, where you see relative total mortality in Norway. This is all-cause mortality by 1 year age groups, both genders combined. And you see 1918 relative to the average all-cause mortality of the years, 3 years leading up to 1918. So what you clearly see is that you have a peak in mortality among young adults as expected, but you also see that there's actually a negative excess mortality for the elderly. So above the age of 70, there's actually lower mortality compared to baseline, which is quite amazing. And it's backing this idea that I just tossed out at the beginning of my talk, saying that if it wasn't for some sort of immunity among the elderly and among people living in urban areas across the world, the 1980 flu would have been a lot worse than its reputation. We also saw this in 2009, that the elderly had some pre-existing immunity to fight the so-called swine influenza in 2009. So the further you were, I mean, the older you were, and the older, and if your birth cohort was just after the 1980 flu, the stronger that pre-existing immunity was. So people that experienced the 1980 flu and also the H1N1 virus in the 20s, and also later via vaccination, got some immunity to fight that swine flu also in 2009. Here's a graph coming from Nature Immunology, picturing the U-shaped curve for mortality at the top, the WH-shaped mortality in the middle. And what Palesi and Olston suggested in 2007 was that people living in isolated areas of the globe, did they have a V-shaped mortality curve rather than a W-shaped one, due to a lack of immunity? So hence, if they had less experience with the H1 virus or other types of influenza viruses in the past, due to isolation, they could easily have a V-shaped mortality pattern rather than a W-shaped one, and with only survivors in some communities, which would be really, really isolated, would be kids between the age of 5 and 14. And what I did in 2008 was to start to gather data for isolated communities in Scandinavia, in the Pacific, and in Northern America. And these are my findings. So what we basically saw was that isolated indigenous people had 3 to 5 times higher mortality than the white counterparts living in more urban areas within the sort of the same continents or some of the same countries or areas. And a staggering high mortality in Labrador. A third died in Labrador. Western Samoa, 25% died. Alaska, on average, 8% died. Enare, this is northern Finland, in Lapland or Sapmi area, 10% died. In Arjeplog, this is Sweden, also Sapmi area, Sami area, 3% died. And in Karasjok, this is in Norway, 2% died. And the average, if you remember that figure for Norway, was 0.7. So you had a lot higher mortality in these isolated indigenous areas. And this graph is showing the worst case I've ever seen for the 1918 flu pandemic. 90% died in Brevik, Alaska. And here you see that V-shaped pattern predicted by Palesi and Olston and these guys in 2007, or a square root shaped H pattern of death. So you see basically all of the infants and the young children are dying, and the only who survives are a handful of children in the ages of 10 to 14, while all the parents died. And you see it also in this picture here, right? That this is ethnographic evidence of this idea of only children surviving. This is an orphanage in Norstak, Alaska, showing the prediction of that model and also the empirical results from my study from 2011, showing that it's only the kids between 5 and 14 who survived. All of the adults had died, including the infants. So why would young adults be so much at risk? And there's 4 theories out there. So less immunity among the young adults compared to the elderly, maybe a cytokine storm. So it's a sort of a so young adults, they have very strong immune systems. But in meeting with this H1N1 virus in 1918, they experienced this multi-organ failure with a collapse in lungs and heart and everything. That's a cytokine storm. Tuberculosis is a risk factor, and young adults that had a latent TB were at risk for sure. And that's one explanation as well. And there's one idea out there also saying that if you were exposed to the so-called Russian flu pandemic in 1889, could that be negative when you encountered the H1N1 flu virus 30 years later? Some people, including a colleague of mine, Lone Simonsen, is now suggesting that this pandemic was maybe caused by a coronavirus and not flu. That's an exciting idea here. But we still don't know too much about why young adults were so at risk. So we definitely need more research here. So I'm coming to the end of my talk here. It's just showing on the left-hand side here the crude deaths per age, per gender. Showing what we know already, that it's the elderly that are at risk. And on the right-hand side, you see the infectious fatality rate for COVID is definitely increasing with age. Now to the second component of the recovery agenda. So these SCR models are assuming that that people are, okay, so most people survive these pandemics. Actually, I mean, 99 or 98% of those that got infected in 1918, they actually survived. So yes, people survive these pandemics, but do all completely recover. There's a big literature out there, especially looking at being exposed in utero and later life health and social consequences, showing it was negative to be allegedly exposed in utero, in terms of high school dropouts, in terms of having lower incomes and education later in life, in terms of having more functional limitations and more health problems and even higher mortality later in life. So this was negative in 1918, and luckily pregnant women are not at risk during COVID, it appears. So this is not a risk factor now. But there's a huge literature out there also showing that there was an increase in depressions and suicides and even asylum hospitalizations and poverty associated with the 1980 flu pandemic. And you could also ask now, what about long COVID, or the so-called long haulers of COVID? There's lots of anecdotes out there still, so we need more studies here for sure. ICU patients are not recovering fully, it seems. There's even reports from Italy of increase in suicides, and also for other countries. And are people also struggling like they did after the 1980 flu, and also like Edvard Munch here did, the famous Norwegian painter. He painted two self-portraits showing the sort of the time of the 1980 flu. We're not sure if he actually had the disease, but it's a struggle to live through times of pandemics, and it might have mental health consequences for sure. And there's coming out several studies now also even showing that there's a bi-directional association between mental illness and COVID. So mental illness in itself may also be a risk factor for a severe disease during COVID, and also an independent risk factor for a increase in mental health issues after COVID. So people that haven't had mental health issues are having mental health issues after going through COVID, it seems, according to some studies at least. Then, almost finally, is it really true that these SCR models postulates that people recover and then they get immune, right? And that's why these pandemics also disappears, because people are going through it. Most survive and they get immunity. And going through the summer wave in 1918 definitely left some immunity to fight later waves. We saw it for men having a higher morbidity compared to women in the summer, and that sex difference twisted in the fall in Bergen. I've also done another study showing that the poorest people of Bergen got hit the hardest in the summer, but it was the richest in Bergen being hit the hardest in the fall. So going through these different waves definitely leaves some types of immunity to fight later waves. And we've also seen a number of studies now showing that going through a mild to moderate COVID experience also gives some antibodies. And I even saw this morning that there was a new Swedish study, I haven't read it yet, showing that these types of immunities and antibodies are actually there also after 9 months. So this is these are good news indeed, that it leaves immunity going through the disease. To conclude, all people are actually not susceptible. Some are actually partly immune at baseline. So that goes through this assumption that everyone is at risk and are susceptible when new pandemics comes. There's large variation in mortality by both medical and social risk factors. Most people actually survive these pandemics and gain immunity, it seems, but some may not recover completely, either in the short or long run. But we definitely need more studies here on the so-called long haulers of COVID to be concluding on this topic. and COVID-19 is not over. So we can have new ways, and even with vaccination programs now having started to be rolled out in many countries, that's just a sad fact that we might see new ways. Thank you so much.
Thank you, Svenn-Erik. Some very interesting and important trends about differential susceptibility, some counterintuitive. I look forward to actually reading your papers. Roger, you're up next, please.
You're on mute, Roger.
Yeah.
I am so sorry that this still happens after what does this every day is quite remarkable. So let me start here again. So can everybody hear me now and see my slides, I hope?
Yes.
Yes, good. Okay, so sorry about that. I am a political scientist, and I come at this from a very different place than some of the people before. And I now, in the interest of our time, I will also try to go through this in less than the time I had planned, and I will rush through some of the slides because I know James is still coming after me. So here, my interface or my interest for this particular talk today is the interface between the two words of pandemic and democracy. And obviously demos is in the core of it. It doesn't have to be, schooled in Greek to understand that these are this root of the term is there because it means people, and it's all people for the pandemic, and it's the rule of the people for democracy. And the puzzling thing, of course, is that something that may be easy to understand for everyone intuitively, but it is a huge problem for somebody like myself, who is a political scientist who studies these things, is that of course not everybody is, as we just heard, susceptible to or infected by a pandemic. So it's not all the people are infected by the pandemic, but also on the democratic side, even though some countries, and the countries that I'm looking at today, Italy, Germany, and Canada, are democracies in letter, not everybody participates in democracy in the same way. So we have a double problem here that we need to resolve, and we're in the middle of a pandemic. As we just heard, it's not over. And so we need to think about this a little bit. So the three countries that I have chosen for today's explication are three liberal democracies: Canada, Germany, and Italy. They are G7 members, they're NATO members, they are more or less symmetrical federal countries, they're highly urbanized, mostly export-oriented, there's also some import orientation, they're globalized, and they are increasingly multicultural in their societal makeup. They had to learn hard lessons in this pandemic because as we were coming in, and I was actually living in Germany a year ago, so I saw it develop from there before I returned to Canada. They were amongst the hardest hit countries by the pandemic in the world, despite their position as being 2 or 3 of the richest countries in the world. They have highly developed and resourced healthcare systems, and they have sound scientific determination and self-assured bravado at the beginning of this. When you listen to German television and radio in February of last year, they said, we have this under control, this is not going to be our problem. And the same was true for Canada and for Italy. Of course, Italy is a little bit of an outlier because they were hit first and hardest in Europe together with Spain, so that's a bit of a different situation. They were self-confident, and there was something that I would call, in hindsight, self-assured leadership. There was a lot of performative politics. Merkel in particular became sort of the anti-Trump figure in global politics. who is a scientist herself. And of course, Christian Drosten, her main influence at the beginning, and still the famous virologist, co-discoverer of the SARS, original SARS virus, stood by her side, often, in reality. Trudeau, our prime minister here in Canada, stood in front of his residence every morning, every afternoon, and made a straight face in a difficult situation. And even the former Prime Minister of Italy, Conte, said early in the pandemic, as everything was falling apart, the state is here. We are here to protect you. There was a little bit of a lack of modesty, as I already said, in those liberal democracies, as they were saying, we have this under control. But now, 12 months later, we also have seen that this lack of modesty also extends to a little bit of an unwillingness to admit that they're part of a global community. So Exhibit 1 is something that Dr. Fallah knows much about and has recently written about, is the COVAX process, where Canada now has secured its share, which they say their fair share of the vaccines. Exhibit 2 is that a lot of the European countries that are doing well in this and pride themselves of being at the front of having organized healthcare systems have actually benefited from the brain drain from mostly Eastern European, but also African countries, where doctors are sorely needed, but they are now working in German or in Belgian or Italian hospitals, which is really not, it needs to be talked about if we talk about democracy, because, if the conditions from which you start a pandemic like that are so slanted against you, you do have a problem. So here are the case numbers. The only thing that needs to be pointed out is that all three countries have way higher in the COVID ranking than they are in the population ranking. That's all we need to know from this table. Of course, Italy is still the most affected country of the three. Canada is not doing very well. All of them have seen second waves. And now, of course, today in Canada, we are fearing the third wave on our doorstep more than in these other two countries in a way. There are questions that we can generally ask about COVID and democratic society and institutions. These are unprecedented problems. We've just heard a talk about 1918. This has always been sort of the specter of the reference case for what will happen to a society, what will happen to a democratic system if we have something like the Spanish flu. That was always sort of, talk. Now we have something like that, but for most of us, for all of us actually, that are listening into this, we are younger than we wouldn't have had this experience. Our countries have been seemingly well prepared, but there was structural underfunding of healthcare systems in Canada, Italy, and Germany. 30 years of neoliberalism and austerity policies show their traces here. There are recent trends in Canada, Germany, and Italy for healthcare reforms that may have weakened the cohesion of the system. One example, obviously, is the profit-oriented over public orientation in healthcare, in particular long-term care. That is a double problem. On the one hand, the privatization has led to an increase in the numbers of infections and death in long-term care homes, but also it reflects on the particular type of work relationships, labor relationships in those institutions that have been underexposed, were underexposed before the pandemic. Particularly the immigrant labor, low-wage precarious labor is affected here. Then there are structural deficiencies across state territories and urban regions. Those democratic states are not the same everywhere. We have a good example here in Canada, in Ontario, outside of Toronto, the large suburban region of Keil, which has been a hotspot, structural underfunding of the health systems, compounding problems of societal susceptibility, to use this language, and that has now created a huge crisis. Another question generally for political scientists, it's more or less academic, but it has become a real problem. Is our federal systems more affected by those kinds of problems than more centralized system? It's hard to believe if you look at the UK that this would be the case, but it's a question that we should ask. And of course, the United States is a good example of how federalism failed. Then the question is of the late political scientist Benjamin Barber, who asked, with particular respect to pandemic threats, whether this is the crisis of the nation state. If the nation state is about secure boundaries and sovereignty, what does that even mean in an age of pandemic where the virus travels quickly, swiftly across these borders? How can we even talk about the nation state as a protector? And so people like David Fidler have for about 20 years now talked about a post-Westphalian, post-national virus situation. What I'm not going to talk about for the rest of the time that I have is what we need to talk about, which is how are we set up? And Dr. Fallah's example of how well Liberia has prepared, we could ask Canada that question. Why did we not prepare well? Why did we not create institutions in this country after we had the warning from the SARS epidemic of 2003? Why did we not restructure our healthcare system in that manner? But I don't have the time today to do that in a comparative way. What I also don't want to talk about, even though it needs to be talked about, is what happened at the margins, particularly the right-wing populist margins of these democratic societies. On the right, you see an example from Germany, people that have been called, in not so nice language, COVIDiots, people who pretend the crisis does not exist. And often these kinds of situations have been aligned with right-wing populist and even fascist movements in Europe, but also, of course, in the United States. On the left is an example from yesterday. Here in Kelowna, in Canada, COVID protesters want transparency and choice. People, out there demonstrating for their civic rights of information, but not always with the best ideas in mind. I spare you explaining this Mardi Gras related, because today is Mardi Gras. For those of you who speak German, you can quickly read it. This is about carnival and fascists, but I'll leave that for another time. So there are some differences in all these places, and I'm just going to highlight a few. I'm relying here on Richard Horton's idea of syndemic politics, or a syndemic rather than a pandemic situation, where many societal factors are coming together and need to be governed and need to be democratically dealt with. In North America, more than in Europe, so in Canada as opposed to Germany and Italy, the Black Lives Matter movement changed the democratic discourse in this country dramatically in the course of 2020 and changed the way we talked about the disease. So in Canada, in April and May, it became clear that we needed to have race-based data for what was going on in terms of infections and disease. The racialization of the disease, the regional differences, particularly indigenous communities in the north, that needed to be taken into account. And it was those communities themselves that created democratic claims onto the state to say, we need those numbers, we need to understand what is going on. That was basically non-existent in Italy and Germany as part of the democratic discourse. Whether you were a Black person in Germany or not was not really a statistical piece of information. It wasn't taken into account when we counted who was affected by the disease. So here you see differences amongst those democracies, and we need to think about what the reflection of that is on democratic citizenship overall. So there are some path-dependent predispositions. Germans and Italians have different ideas about what kind of countries they are. The immigrant country of Canada has a different predisposition in that way. But also there were different reveals. What did people want to know about themselves in those countries, which we need to think about. All of this in the end, 100 years from now, We will look back and to see what was the grand lesson of this, and perhaps there was none. What we can say now is that have been going through a democratic moment. Questions were asked that hadn't been asked before. Whether that will lead to a democratic movement, we shall see. And whether that democratic movement will lead to a new democratic consensus about how to move on will be another question that is different. So quickly to go through this, to say, when I say democracy, it's on the one hand a commitment to a democratic rule book, to say we're all in this is a pandemic and a democracy, but also the main issue to be discerned from this is, of course, the question about substantive democratization. You know, who gains from this? Is it all going to the big digital corporations? You know, who will in the end benefit from this democratic moment? So I'll go quickly. This is where I'm going to skip a few things to wrap up. What I'm doing a lot of work on, and also with Harris Ali, are these changing spaces of democratization. And here, if you look at just some of those maps, you can see how difficult it is to begin to understand the geography of democracy and the geography of the pandemic. Anybody who knows a little bit about the history of Germany over the last 50 years will understand that this map of infections, the darker red, the more infections of a couple of weeks ago, is quite concerning, right? Because the wall seems to be back up here in between West Germany and East Germany. These are the kinds of things we need to talk about. In Italy, if we look at a map of the region of Milan, it is an interesting move from the east of the region to the west of the region in terms of the infection rates. That needs to be explained. We need to have an understanding of what is the basis of this kind of infection. In Toronto, as I already have mentioned, it is particularly the poorer, less resourced inner suburbs and outer suburbs, immigrant suburbs of the urban region that have been most affected. This geography will give us democratic questions to ask about. Also, that goes into the vaccine distribution, of course. This is not a map of Toronto, it's one of Chicago. And you can see, while most of the cases have been in the poorer inner city neighborhoods in the east, in the west of the city, most of the people who have, until last week, received the vaccines are in the upper northwest corner of the city, where most of the white and wealthy people live. So that is something that we need to talk about. So the city itself, the urban region, becomes a democratic space that we need to think more about. That's where much of my work is. There will be divergent models for that. Again, Toronto, Berlin, and Milan have different ways of dealing with this particular thing. There will be debates, and they are inevitable in democracy. It cannot be decided from the top down. There are crises of legitimacy that need to be dealt with, maybe as elections are coming our way, but also we need to think from the bottom up, what are the processes by which even have this kind of democratic movement? Now, to come to a close, when we come out of this from a democratic point of view, we need to think about the preparation for the future health challenges that come our way. But we also need to change the social reality that has shown to be so vulnerable to and susceptible to infection. So we need to think about who did we forget before, and what do we need to do as a society to prop up the resilience of those groups as we're moving forward. So we need to change a few of the ways in which we have lived, because they have shown to be not very well disposed to fight off the next pandemic, even though the next pandemic can be entirely different. But we need to think about those social relationships in a democratic conversation and to move on from there. So thanks very much. And I hope that I didn't go over time too much.
Thank you very much, Roger. And the sort of spatial geographic trends that you were talking about, and the demographic trends that Svenn-Erik were talking about, I mean, they all have political implications, and that's what you were bringing up, implications for politics, for polity, and governance. And I use that as a segue for our fourth and not last speaker, Dr. James Orbinski, who may be talking a bit about governance. I don't know. James, you're up next.
Okay, thank you, Harris. I'd just like to share my slides if I could. I'm going to put these up and let me know if I've got everything. Like from the start. Okay, can you see a full screen of a slide?
Yes, James, it looks good.
Okay, terrific. So I basically just want to talk about a couple of critical lessons, which obviously I think have implications for governance, which I hope in the remaining time we can talk about a little bit. In my experience, I know that access to healthcare technologies, whether it's drugs, diagnostics, or vaccines, really matters to people's lives. This is an image of a man with HIV in the mid-90s, before he had access to treatment. And this is the same guy 6 months after having started treatment for HIV. So access to healthcare technologies, again, whether it's drugs, diagnostics, or vaccines, actually has profound human implications, as well as obviously profound secondary, I would argue, implications for national, regional, and geopolitical stability. This is a chart that just shows on your left, in blue and in red, the overall impact of access to antiretroviral therapy for the treatment of HIV. Access essentially occurred between 2000 and 2010. That's really where the rollout of antiretrovirals to much of the world really took place. And what the red shows you is the deaths that were averted or that did not happen as a consequence of access to treatment. What it also shows you is a declining rate of HIV deaths, which demonstrates very nicely that in this particular case, and as is the case in fact in many, but not all, infectious diseases, access to treatment is a form, and in fact, a profoundly important form of prevention. So treating a person with a disease actually, in many cases, prevents others from getting it. A very simple, basic idea, but fundamental to understanding the nature of epidemic disease and pandemic disease. We also know that in dealing with HIV, just as an example, the approach to intellectual property, the approach to the governance of the design and access to a particular technology had and continues to have a profound impact on access to a particular technology. This is equally important today when we talk about vaccines, which is really what I want to talk about. We also know that for the HIV pandemic, it was only through a deep, engaged, coordinated, systematic, and highly rational activism globally that access to antiretrovirals actually occurred. I don't want to go through the history of that, but I think that is, I hope, well understood. But I want to remind people of that point. So COVID today, here's a picture from the now famous Hopkins dashboard from last night. We have over 100 million confirmed cases, about 2.4 million confirmed deaths. And we also know that, as has already been pointed out, this is one of several, if not many, subsequent waves that we can expect over the coming the coming months, if not years. I want to just drill down to one little country right now, Malawi, southern region of Africa, deeply and profoundly affected today by COVID and by a variant of concern, the South African variant of concern, which has now emerged in South Africa and spread to at least 29 different countries around the world, but most significantly, has spread very, very precipitously across the southern region of Africa and is affecting a large number of people. It is much more transmissible, between 30 and 70% more transmissible, and the mortality rate associated with this particular variant is 3 to 4 times higher than the mortality rate associated with the resident variant or the original variant. We know that very practically in Malawi, it's a country that I know very well. I've worked there for more than 15 years over the course of my professional life. And I have many, many friends and relationships and research projects and programs there. What people are telling me is that the biggest issue right now is that there are really 3. One is that for treatment of COVID, there are very significant oxygen shortages. Oxygen is actually the most effective treatment for COVID, as we know today. I mean, there are all kinds of trials underway for many treatments and many drugs, but even relative to corticosteroids, which are extremely important for the clinical treatment of COVID, oxygen is far more important. And oxygen, there are massive shortages across the country now because of COVID. Also, many people are dying and will die at home. And that's because people are afraid to go to the hospital. People know that when they go to the hospital, there won't be actually any treatment. There won't be oxygen, there won't be enough healthcare workers, there won't be enough available drugs, even basic drugs like acetaminophen or corticosteroids. These are in rapid declining supply because of the reality of COVID. And then the other major reality is that what the country needs today is 40,000 vaccines to vaccinate frontline healthcare workers in their hospitals and clinics. And the reality is that today, there's very little likelihood that they will get those vaccines. There are now, just to summarize a little bit, 7 times more confirmed cases in the second wave of COVID relative to the first in Malawi, much more transmissible, higher mortality. There's almost a state of shock within the healthcare system in the sense, and really driven by the rapidity with which people decline once they're ill. It's very fast. It's not like HIV, it's not like TB, it's not like even an acute pneumonia. It's very quick and very fast, and it's quite shocking to people. And vaccines are fundamentally needed for frontline health workers. And Malawi, like 96 other countries around the world, are dependent on COVAX, which is I'll talk about that in a moment. The AstraZeneca vaccine was or is to be available by the end of February in Malawi, but the chances that will actually happen are significantly diminished with each passing day. At the same time, the AstraZeneca vaccine has actually been canceled. The rollout of the vaccine has been canceled for South Africa because of the emergence of this new variant of concern, and for which the vaccine has no significant clinical impact in terms of reducing the volume of the number of people actually arriving at hospitals for treatment. So it's not actually effective from a public health perspective, a broad public health perspective, in terms of having a significant impact on the ability of the clinical public health system to treat, contain, control COVID. Globally, there are now 9 authorized vaccines, and there are variations around those authorizations. Some are national. WHO has authorized 4 for emergency use, which has very significant implications for developing world. There are also 378 other vaccine candidates that are in various stages of the R&D pipeline. The attrition rates, of course, for vaccine development are extremely high. So we'll see how many of those vaccines come to fruition in terms of efficacy. At the same time, for the 9 authorized vaccines and for a small number of the 378, for which there's a very high probability that they will become or they will be identified in past clinical trials and be identified as effective, 12.8 billion doses of vaccines have already been reserved through advanced purchase agreements by individual nation states. And 16% of the world's population have already reserved 60% of available vaccine supply. So that's really another way of saying the same thing. 16% of the world's population has reserved 12.8 billion doses of existing and future vaccine supply. Canada and the United Kingdom have actually purchased enough vaccines to cover 500% and 300% of their populations respectively. And just let's go back to Malawi. What Malawi needs is 40,000 AstraZeneca vaccines right now, or another vaccine that has high clinical impact for the current strain. It's just another way of showing the same thing. Essentially, North American countries have bought enough vaccines to more than double or triple their coverage of their population. And this, again, if you just look at the top here, Canada, our country that most of us are from on this panel, we are actually, we have the highest rate of vaccine coverage and the highest number of advanced purchasing agreements than any other country in the world. What it means essentially is high income countries, and we're the best, if you will, or worst, if you will, example of that. High income countries are essentially hedging their bets, while low income countries are essentially being left out of functional access to vaccines. The WHO established a system called the ACT system, or it's a platform that ensures access to COVID tools. And part of that partnership, which seeks to coordinate the production and boost access to treatments, vaccines, and tests, part of the ACT platform is COVAX, which is specifically focused on vaccines. And their goal, COVAX, their goal is to distribute 2.1 billion doses of COVID-19 vaccines globally by the end of this year. And 690 million of those are forecast for African countries. And the goal is to cover 20% of the most at high risk population within 94 COVAX signatory countries. The vast majority of the world's population live in COVAX dependent countries. So the vast majority of people in the world are dependent on COVAX for their access to vaccine. Yet we know that now current models are really telling us very clearly that there won't be enough vaccines to cover the world's population until 2023 or 2024. So we're a long way off actually from full coverage. We also know, as Roger has indicated, that the variant of concern that I'm talking about here from Malawi, the South African variant, is now actually here in Ontario. We had our first case 2 weeks ago, and as of yesterday, we have 6 cases in Toronto, and we also, as a point of interest, have 300 cases of the British variant of concern. This is a picture of a condo building wherein everyone in the building has now been tested as of last night here in Toronto for the South African variant. So my point here is that the waves of variants that are now coming. This is, first of all, an inevitable reality associated with any viral, especially viral, any viral infectious disease. The emergence of different strains is just part of the natural life cycle of a particular virus and of its of a particular species within that viral group. But so we are going to see, and I think this is a very basic but very important point, we're going to see the emergence of multiple variants in the very near future and perhaps in perpetuity. And so the question of vaccination and the question of access to vaccines it's not simply a matter of protecting yourself within your little bubble, your little Canadian bubble, your little Norwegian bubble, or your little Italian bubble. The fact is that the risk to any one is dependent on the emergence of strains globally, and therefore the approach that one must take must be a global approach, a global coordinated approach that includes an approach to equitable access to vaccines. And I'll just close by saying that the coronavirus, or COVID, is just the latest in a series of infectious agents that are becoming increasingly more prevalent and are going to become increasingly more prevalent in the very near future as human beings increase their population, their urbanization, and their degree of ecological impingement, and the degree to which we are altering the biosphere in which and from which we live. So approaching vaccine and other healthcare technology access from an equitable perspective is, in my view, a self-evident necessity to ensuring the wellness and thrivability, if you will, of humanity. And those are essentially my comments. Thank you.
Okay, thank you, James, very much. So we have a few minutes for questions, and I've asked Sabah to coordinate that. So if you could.
Thanks, Harris. Thank you to all the speakers. It was very, very interesting. I have personally many questions. We had the first few questions were for Dr. Shipenda, but I'm not sure if he is still here. So I will ask the next question to Dr. Raje. The question was, what do you make of the current trend of militarizing the pandemic response? Are there risks for the military overthrow of democracy if nations are threatened with future pandemics?
Thank you for that question. This is really a tremendously important question. I think that is a concern in all places. You know, my particular sample for this research is those, and I mentioned it a number of times, liberal democracies who think themselves of having the rule of law. But, you know, we already see that here we have problems generally in these democracies. And we had the case, of course, south of, in that big country that shall be unnamed, south of Canada, where we've had quite a merging of different aspects of democratic decision making. And we see other countries like Brazil or Hungary, which has just banned its last critical radio station, and other countries that I need not to name, where these concerns are there about the overstepping of those boundaries and the and potentially bigger roles for non-constitutional actors that could include the military, but could also include others, of course, to step into the breach here and to make decisions that will not just affect the current situation of distribution of vaccines, for example, but also redistribution of societal resources for the time to come in the future. These are concerns for all countries, and the ones I named are on everybody's mind. But we all need to be very worried and aware of those things. It's also important that for those of us who are a little older, now that these vaccination centers are being set up, and that started in Italy, of course, in March, when you saw trucks full of bodies going through the streets, military trucks, images of war that have come to many countries with the vaccination centers. Now you have mass events that look very militarized. You know, we are now a population that likes mass events when there is an Ariana Grande concert or a Drake concert, to bring a Toronto example. We don't like so much those kinds of mass political events that are organized by the state or by the military. So when you have a mass vaccination event in a stadium or in a conference center, people my age will think of other things, Chile in 1973 or some other aspects that are less salubrious than what we would like them to be. So thanks for that question. I cannot answer it in full. These are just some ways in which we need to think forward here.
Thank you so much, Dr. Rajay. It's very enlightening. It's definitely a murky time politically, and democracy has, taken on so many different meanings in such a short amount of time. So thank you very much for elaborating. I have a question for Dr. Svenn-Erik. I'm wondering, you briefly mentioned the sort of bidirectional association between mental health and COVID risk and severity. I was wondering if perhaps you could speak a little bit more to that, about what you've read or what you've come across.
Yes, thank you. I've done one study myself looking at the 1918 influenza pandemic, comparing staff and patients at asylum hospitalizations in 1918, where we had data in infections and deaths, and found a 10 times higher mortality among the patients compared to the staff who were thought to be, healthy. At least they would not have, mental illnesses that required hospitalization. So there would be a good control group comparing these patients to. That's the only study I've seen for the 1980 flu, actually. So we definitely need more studies on that pandemic, and also that for the 2009 pandemic. I haven't seen any studies looking at the impact of mental illnesses or as a risk factor for the Asian flu or Hong Kong flu. But they're ticking in new studies now, showing that it seems to be and that mental illness seems to be an independent risk factor, actually net of NCDs, non-communicable diseases, heart disease, lung diseases, and so on. And also that it seems like previously healthy people are actually having, are at the increased risk of getting mental health issues going through the pandemic. But again, I find it hard to sort of believe that the context itself would not matter as well. I mean, so obviously a viral disease can definitely have that impact on your mental health. But going through a crisis, going through a pandemic, there's this burden of all of these curfews and lockdowns on unemployment. We know unemployment is related to health, and if you are experiencing bereavement, if you lose somebody in your close family and have been going through the disease yourself, it's going to be hard to sort of disentangling the sort of the independent impact of going through that viral disease from all of these other factors that are going on at the same time.
Thank you so much. That's definitely something to think about a little bit further, especially because our work here at the lab is mostly mental health. So that's why I asked it. Very interesting point. Thank you so much. I believe Harris,
Yes.
Dr. Harris Ali has a follow-up question.
Thank you, Sabah. I will ask one final question and then we will wrap up. And it was an interesting point that Svenn-Erik raised about how certain individuals would go from Norway to skiing in Italy, then come back and the disease would be transmitted to Oslo. And this was a wealthier class. But this is an interesting thing. And I want to ask Dr. Mosoka Fallah about this because Mosoka, you had interesting observations about social class differences in disease transmission in comparing Ebola to COVID. Could you just go over that before we conclude?
Yeah, thank you. What we observed is very interesting is that Ebola was a disease of the poor. We saw the big outbreak in the urban slum or the informal settlement. And the way the disease tended, I'm trying to look at, I said, Ebola, what we saw, Ebola was concentrated among the urban poor, the urban slum dwellers, informal settlements. And the way we observed Ebola left from the urban settlement to the suburb was through economic activities. The poor tend to be the ones that serve as the drivers, the cook, and the maid. And so through that means, we observed that disease left from the informal settlement to the upper class. But with COVID, it is the reverse all across West Africa. The disease was brought to West Africa or most of the African countries by those with upper socioeconomic status that either went for conferences or businesses. They brought it to their country, like Liberia, the case of the director of this institute. But what we saw happening is that the disease then left the upper social classes to the poorer community by the same economic activities. So the cook and the maid took care of their bosses and they brought the diseases back to the urban slum. So it's a complete reverse we're seeing between, and so the conduit of infectious diseases, depending on the context, can be from both ends, and economic and social class can sort of serve as a reverse transmission of the disease. That's what we already observe.
Yes, I think it's a very important insight as we develop our disease responses for the future, the role of social class in the direction of the disease transmission. So thank you for that response, Dr. Fallah. And I need to conclude now, but before concluding, I would like to mention, first of all, a hearty thank you to all of our presenters who gave very excellent presentations. I learned a great deal, and I hope everyone in the audience did as well. And thank you for taking time out from your busy schedule to accommodate us. Now, the next session will be on Tuesday, March 16, and it's the topic for the panelists will be global mental health in pandemic context, facts, prevention, and intervention. So that's Tuesday, March 16th, okay, at the same time. All right, everyone, thank you, and I bid you adieu.